Hello, and welcome to another edition of the Society of Critical Care Medicine's Eye Critical Care podcast. I'm your host, Dr. Michael Weinstein. Today, I have the pleasure of speaking with Saqib A. Chaudhry, MD, who is lead author on an article published in the June Critical Care Medicine entitled Impact of Advanced Healthcare Directives on Treatment Decision by Physicians in Patients with Acute Stroke. Chaudhry is a clinical research fellow at Zinat Qureshi Stroke Center at the University of Minnesota in Minneapolis, Minnesota. He is also an associate editor for the Journal of Vascular Interventional Neurology and co-investigator for implications and challenges of long-term structured follow-up in the management of acute stroke patients. Thank you so much for being here, Dr. Chaudhry.
Thank you very much, Dr. Weinstein, for giving us the opportunity.
Thank you. Your paper provides a very interesting perspective regarding advanced directives, perhaps in general, but certainly more specifically in patients with stroke, and gives a nice review of some of the historic background of advanced directives in stroke and patient preferences regarding disability. And I was hoping you can elaborate on that a little bit.
Sure. Thank you. As we all know, stroke is the leading cause of long-term disability in the United States, and stroke survivors have significantly lower quality of not only mental but physical health. The decrease of the quality of life is more pronounced as compared to any other medical illnesses, and as we know, a wide range of severity is commonly seen in stroke patients. And despite there was a study done in 2005 which showed almost 1.1 million stroke survivors have some kind of disability, ranging from all the way to mild severity to severe disabilities. And here I would like to mention two previously published studies, one done by Dr. Hanger and the other one done by Dr. Nakagawa, and they actually studied the impact of the stroke on the quality of the life afterwards. Dr. Hanger actually did a survey of the stroke survivors, and in which we learned that almost 1/3 of the elderly individuals who have some kind of stroke disability would rather like to have a painless death as compared to minor stroke disability. And in the same study, they also showed that 80% of the people would rather like to die as compared to the severe disability comprising of hemiplegia or quadriplegia. And the second study, which was done by Dr. Nakagawa, he did a survey of young adults in the United States and showed that about 1/3 of the young adults would rather not like to have aggressive procedures. And in the same studies, they were able to demonstrate that about 60% of the young adults would rather not like to have any kind of severe disability after going through the aggressive procedures, and would rather like to have a comfort care measures taken if the clinical situation comes to that point. In that study, 1/3 of the patient family would rather not like to have the procedures after seeing the outcomes of those aggressive procedures. So in this scenario, we are in a very difficult situation to how aggressive we should go with these aggressive procedures in the scenario that we don't have any further feedback from the patient perspective. The only thing we're left with is our own physician's clinical judgment and a limited feedback from the family perspective. So we performed this study to identify the impact of existing advanced directives, which are usually done when the patient can make the clinical decisions, and its impact based on the clinical decisions if the situation arises.
Yeah, I always have trouble interpreting some of those studies in that, I take care of a lot of patients with spinal cord injury, and the ability for humans to adapt to new circumstances, despite imagining a very poor quality of life before things actually occur, so before an acute illness occurs, the change over time I find remarkable, so that while many folks would say that they would never live or want to live as a tetraplegic, many patients end up doing so and living quite fulfilling lives. So I always wonder how to interpret that information.
You're absolutely right. So the two studies which I mentioned earlier, one was, a completely healthy survivors, and the other study was the stroke survivors. So that's why I was trying to show the difference in the opinion. But you're right. It's a very difficult situation for us to make the judgments how these severely debilitating diseases impact the judgment of the patients after the disease. A lot of people take initiative saying that they would not like to have the procedures, but when they're actually in that situation, then it's become difficult. And that's the whole difficulty of having an advanced directive, why we don't have a clear-cut wishes written in there, and making the judgment become so hard in those scenarios.
Great, yeah. Can you elaborate a bit more, both broadly and specifically, about how you decided to go about providing some answers to these questions?
Well, to study, it's a very difficult topic because selection of the patients in a case and control kind of impact cannot be applied here. So what we did is we selected 28 consecutive patients who presented to a comprehensive stroke center, and based on that, the study consisted of three basic components. One was the clinical description of the patient presentation. Second one was a copy of the advanced directive, which was available at the time of the presentation to the emergency department. And the third was study questionnaire.
Yeah, so the 28 patients that you selected out of the many more, the criteria then were that they all had advanced directives available in a document form on admission?
Actually, the way the study was done, we do have a prospectively directory maintained at our institution, and we went through 271 patient charts and selected the 28 patients who mentioned they have the advanced directive at the presentation. And then from those 78 patients, we selected the 28 consecutive patients who had the advanced directive at the time of the presentation. Probably those advanced directives were scanned into the system or presented by the family at the time of the presentation to the emergency department. So it was about 1/3 of the patient who presented to the emergency department had their advanced directive already either scanned in or they came with the advanced directive either with a family member or from other agencies.
I see. And then take us through the rest of the methods. What did you then do with the patient records and the advanced directive and the survey?
Sure. As I mentioned earlier, the study consisted of three basic components. The first one was a brief description of the study presentation. What we did is we went through the clinical impression of the neurologist assessing the patient in the emergency department. What is the severity of the neurological deficits based on NIH-SS scores, ECS scores, patient previous comorbidities, presenting symptoms, the time of the onset of the symptoms, then radiological impression, and also the real images of the presentation. We make 1 to 2 paragraphs of the presentation, and all the records were de-identified to meet all the human resources protections law. The second component, study questionnaire, which consisted of 28 clinical decisions. Questions were selected from the previous clinical trials which have already been published or the observational studies. In the past, these clinical factors have been shown to impact the clinical outcome of the patients. We published one study based on these questionnaire in neurocritical care last year showing the impact of the hospital patients scoring higher on these questions were more likely to have less inpatient mortality. So these questions were then further categorized into three things: routine complexity decisions, which are part of the routine care and do not require any special consideration or informed consent from the patient. The second category was moderate complexity and clinical decisions, where we usually don't get informed consent, but meaningful discussion is usually taken place between the physician and the family members if needed. The third was high complexity decisions, which usually need surgery, anesthesia, and usually need informed consent from a family member or if the patient is in a position to give a consent. The last but not the least component was advanced directive, which was already scanned in into that. These advanced directives were further reviewed by 2 lawyers, and those lawyers have enough experience in clinical studies and the clinical trials, and they actually rated the advanced directive based on highly specific, moderate specific, somewhat specific, and non-specific things. Then we studied the impact of it.
I see. So, if I may say it in my own words to make sure that I understand, you selected 28 patients who had stroke that presented through the emergency department, were seen acutely by a stroke neurologist. They all had advanced directives at the time of either presentation or admission to the hospital. And then you took a series of a survey that outlined the important interventions that improve outcomes from stroke, and asked a group of neurologists whether or not they would be appropriate for this patient, given the clinical scenario that you abstracted from the chart, and tried to compare differences between whether or not the neurologist was aware of advanced directives or not.
Yes, you took it absolutely right. To further elaborate on that, the group of physicians which took part into this consisted of neurosurgeon, neurointensivist, vascular neurologist, and also one vascular neurologist from Japan. And they were presented the clinical scenarios with advanced directives, and they were asked to make a clinical judgment. What they will take the decision of making the clinical judgment as yes or no. And then studying the impact of the advanced directive on those clinical scenarios. So the way the study was done was actually in 2 different phases. In the first phase, 14 of the patients had the advanced directive, and 14 patients did not have the advanced directive. Then we presented the same patients after 4 weeks to the same physicians in a crossover manner, and then switched the advanced directive. The ones who did not have the advanced directive in the first phase had the advanced directive with the clinical scenario, and the ones who had it presented in the first scenario did not have it. So in this way, we were able to study impact of the clinical judgment based in the presence or absence of advanced directive.
And when the stroke experts reviewed the clinical scenarios with the advanced directives, did they have the actual advanced directive that the patient presented with?
Yes. So as I mentioned earlier, the advanced directive in the first phase, advanced directive was present. The second phase of the same patient, the advanced directive was absent.
I see.
So we can see whether a clinical decision which was taken in the absence of advanced directive was changed or not changed on the basis of advanced directive.
And then as a third component, you had 2 attorneys review the advanced directives more specifically to evaluate the quality, or I should really say, I guess, the specificness of the advanced directives.
That's exactly right. These advanced directives were presented to the lawyers, and they were given a specific questions to rate the advanced directive based on what kind of information is available in the advanced directive, whether the advanced directive clearly states what decisions should be taken and what should not be taken, whether the advanced directive gave us some recommendation if anything happens in a scenario where patient cannot take any clinical decisions. Well, in that all foreseeable treatment scenarios, the decisions, and there is some direction to take the decisions or not, and then whether compromising all these factors, the advanced directive was comprehensive, subjective, or poor.
Which of the 28 treatment decisions were considered or offered or were performed on the patients in their actual course of therapies?
No, this was actually not based on the actual decisions which were taken. This is
Right.
all based on the study questionnaire.
Did you also look at the actual clinical courses of the patients and as to which of the 28 treatment decision items were either offered or actually carried out in the course of clinical treatment of these patients?
Well, in this study, we did not study the actual decisions which were taken in the neurointensive care. This was all based on the study questionnaire and presenting a real clinical scenario to the physicians, and then seeing their treatment judgments based on the advanced directive and not advanced directives. But to be very specific, these judgments were not compared to the actual decisions which were made in the intensive care.
I see, yeah. And so can you take us through some of the results regarding the medical decisions that the physicians thought were either appropriate or not appropriate? I guess yes or no, right, based on the advanced directives?
Sure. So for the study results, 30.3% of patients presenting to the emergency department had advanced directives, either scanned in or were available later on in the course of it, the agreement of the treatment, and we found that a few highest correlation or agreement was found in treatment of the fever and deep venous thrombosis treatment, and the lowest agreement was found among the physicians for intensive care unit monitoring based on the family physician consideration outside the accepted clinical criteria. Other thing was we also found that there was a good agreement for routine complexity clinical decisions between the physicians, and there was lowest agreement between the moderate or high complexity decisions. We also found that the treatment decisions or the choices of withholding the treatment was remarkably similar among the raters based on the presence or absence of the advanced directives. Also, the last thing was the treatment and decision to withhold the intracranial pressure monitoring or intraventricular catheter placement on the basis of the severe stroke presentation was not different on the basis of presence or absence of advanced healthcare directives.
And so when you say agreement, for instance, for the treatment of fever, you're saying that the advanced directive had no impact on the treatment of fever or not the treatment of fever, or you're talking about the agreement amongst the stroke experts who were reviewing the clinical scenarios?
So basically, the first thing was agreement between the physicians. So there was an almost complete agreement on the basis of the fever and deep venous thrombosis between the physicians. The advanced directive did not play much of a role. The agreement between the physicians over there. We studied the impact of the advanced directive based on the routine complexity decisions, and so fever was among those. There was, at that point, we did not see much of a difference between the high complexity decision and moderate complexity decision.
I believe that if you look at treatments across all complexities, there really was very little difference between whether or not the physician had access to the advanced directive. The treatment decisions were very similar between the two scenarios.
That's right.
And were there any that were that demonstrated some difference or some significant change in having the advanced directive available?
The only treatment decisions that showed some impact of the advanced directives was intensive care unit monitoring, as long as the patient is an acceptable candidate based on the institution criteria. 32% was withheld in the absence of advanced directive, and as compared to 8% was withheld in the presence of advanced directive. And also some treatment for defibrillation in case of cardiac arrest was withheld in 29% as compared to 19% in the presence of advanced directive. But since we have only 28 patients, we really cannot emphasize these results because the power of the study is not enough to say that whether these decisions were really impacted by the advanced directive or not.
So let's start from Table 1 as you've described, and if you can tell us. So in Table 1, there's treatment decisions, and there are two broad columns: in the presence of advanced directives and in the absence of advanced directives. And then within each, there's a percentage agreement per patient to choose yes, and then there's a proportion of times withheld in 168 treatment decisions. And just trying to figure out exactly the difference in what those two columns mean for the listeners. And, I'm just looking through it in many of the columns, especially in the routine complexity decision-making. They add up to 100%, which makes sense to me as you move along. And in a couple of the routine complexity treatment decisions, they don't add up to 100%, and there's a higher proportion of times in which treatment decisions would be withheld. Can you help me just understand that a little bit more?
So basically what we will start on the initial concept of the study, there are two things. One is the agreement between the decisions. And the agreement can be on the basis of, yes, go ahead and do the clinical treatment or the procedures. And most of the columns where you see that withheld add up to 100%, those are routinely complex, because most of the physicians took the decision of going ahead and doing the treatment. For example, deep venous thrombosis treatment, hyperexia treatment, and status epilepticus treatment. But I will put another scenario where some of the physicians agree on the basis, yes, go ahead and do the treatment, and some of the physicians, and in another clinical scenario, most of the clinical physicians do not agree on going ahead during the treatment. So let's take an example of monitoring of the patient in the intensive care unit. In one of the patients, 4 of the clinical physicians agree on doing the treatment, then agreement is around 66%, 4 out of the 6. And if 4 out of the 6 physicians do not agree on keeping the patient anymore in the intensive care unit, the agreement still remains to be 66%, but withheld of the treatment also rises because 4 of the physicians did not see the need of keeping the patient in the intensive care unit anymore. So the agreement can be close to 100%, but withheld of the treatment can also rise on the basis of different modalities. If we go down into the moderate complexity decisions and high complexity decisions, some of those add up to the 100%, but some of them do not add up into 100%. The probable explanation to this is some of the physicians agreed on going ahead and doing the treatment, and so that was a complete agreement. But in some scenarios, they agreed to not to do the treatment, so the agreement remains close to higher percentages, but at the same time, withholding the treatment also rises. And if we compare the two columns based on presence and absence of advanced directives, we really see not a whole lot of difference between the clinical scenarios. So that's how we conclude that there are a couple of options where advanced directive did show some impact on the clinical judgment, but not a whole lot.
And those in particular were some of the routine complexity decisions.
That's exactly it. The more agreement was seen in routine clinical judgment, but lesser was seen in the highly complex and moderate complex, where we really need the advanced directive to play its role to give us the directives how the clinical care should be advanced.
Yeah. So why did the advanced directives not have much of a play? How can we interpret this data and still tell our patients that they need to fill out advanced directives?
Well, we think that there can be two possible explanations. What we did find that advanced directives are being used, but probably the first thing I would like to say that advanced directives do not have adequate or specific information to influence of the medical decision making. So we did see that advanced directives are routinely being used in about 1/3 of the clinical scenarios, but we think they do not have a whole lot of impact on the clinical judgment. There can be two possible explanations for these findings. Firstly, advanced directives in the current format do not provide adequate or specific information to influence the medical decision making. And secondly, the physicians do not make their treatment based on the advanced directive. Rather, they make their decisions based on the feedback, on their own clinical judgment, and the limited feedback which they get from the family.
I don't remember if I saw this in the article or not, but the nature of the advanced directives in terms of the choices that patients had made, did the majority of patients have advanced directives that chose to forego many life-sustaining therapies, or was there a mix?
Well, here, that's why we brought the lawyers to evaluate the advanced directive.
Okay.
What we saw in our study that, almost half of the advanced directive did not have, clear-cut information on the basis, what needs to be done if a clinical, scenario comes up to that presentation. Only 4 of the advanced directive were very clear scenarios which were written based on what needs to be done if a specific scenario comes into that. And then we did a further analysis, which is use only those 4 patients, and then we did see some impact of when we did exploratory analysis on the basis of those 4 advanced directives, where we had clear-cut information provided by the patients that they did impact clinical decisions based on ICU monitoring, acute hypertensive response treatment, and further along.
See, so a sub-analysis of the 4 patients that had fairly specific and contextual advanced directives did influence decision-making by the experienced clinicians reviewing the scenarios.
That's right, yes.
It was interesting. So if you start with 30% of patients have advanced directives when they present with an acute stroke, based on your data at least, and then 4 out of 28 have actual advanced directives that are meaningful and helpful in a particular situation. That's a very small percentage of patients who are presenting with at least a document that demonstrate and helps guide therapies.
Sure, yeah. That's the real message, that most of the time either the advanced directives are missing, and even if they are present, they don't have the adequate information to make the clinical decisions, and that prohibits us to the utilization of the advanced directive in real clinical work.
So what can we do moving forward, and how can we improve this process for both patients with strokes and other patients who present with serious critical illness?
It's a fairly difficult question to answer, but at this time we definitely need more to study how the advanced directive can be improved. In conclusion, I would like to say that our results mandate the steps needs to be taken for the clear understanding among the patients and the lawyers who are involved in making the advanced directive. We also think that maybe involving the physicians in providing their professional opinion while the advanced directives are being prepared, and giving their professional opinion and disease-specific clinical scenarios presenting to the patient and asking them what would they like to do might be able to improve the quality of the advanced directive, and those things need to be included in the advanced directive later on if a situation arises. We know stroke is a fairly acute illness, and not much of it's not a long-term disease, so we don't have much of a time to discuss the options once the stroke hits and causes this debilitating effect. So maybe in advance, when the advanced directives are prepared, if the physicians can provide their professional opinion, that might help in improving the quality of the advanced directives.
Yeah, I mean, stroke in many ways is similar to my world in trauma and critical care, in that patients are faced with a very sudden change in condition and function, and at times with uncertain outcomes, and decision making can be very challenging. I wonder, perhaps advanced directives should, and I think many have both spoken and written about this, but the idea of having advanced directives really outline more so a patient's goals in what's important to them in life and in function, rather than necessarily disease specific, because there's so many different scenarios that can occur that it does become hard to add context to the advanced directive.
Sure.
Well, thank you. It's certainly a very interesting study in some regards. Does paint a difficult problem that we do face in patients with stroke and other acute illnesses, and does suggest that there's much work to be done to improve these processes of care and improve that type of decision making.
Thank you very much for giving us the opportunity and letting us discuss our study in more detail. And we really hope that this will be the first step in further studies which need to be done and advancing the clinical decision-making process in the real world.
Great, and thank you so much for your time. Well, this concludes another edition of the Society of Critical Care Medicine's iCritical Care podcast. Thank you for listening, and please check out our website at www.sccm.org/iCriticalCare for more information. You can now also find us on Stitcher and Beyond Pod, as well as on iTunes. For the iCritical Care podcast, I'm Dr. Michael Weinstein.